Hi everyone, my name is Alexis Connolly, and this is a systematic review about vitamin D for diabetes prevention in obese adults. Vitamin D has become a major cause for concern in the lives of individuals struggling with being overweight and obese and the risk for disease development. Although many try to stay healthy through diet and exercise, vitamin D deficiencies could lead to precursors of type 2 diabetes. The purpose of this systematic review was to determine what effect vitamin D has on insulin sensitivity and insulin resistance in obese individuals at risk for diabetes. The data sources that were included in this review include Gale, Wiley Online Library, and Scopus. The studies were required to be no more than 10 years old with the full text online and be listed as a scholarly article or peer review. The participant criteria was created to focus on adults that were obese and had not had a diagnosis of type 2 diabetes. The interventions for the studies chosen were all of vitamin D with no specific dosage amounts, supplementation forms, or durations. This included 1200 IU per day, 4000 IU per day, and an injection of 240,000 IU as 3 separate doses. The results of the systematic review indicated that vitamin D supplementation of greater or equal to 4,000 IU of any kind decreased the severity of vitamin D deficiency and improved insulin sensitivity in a span between 6 to 16 weeks in all but one study. Limitations recognized in the process of the study included the small sample size of each study, the fact that the healthy baseline was slightly better than the researchers had wanted based on criteria, and that there were very high dropout rates for each study before follow-up. Vitamin D is a fat-soluble vitamin and can be consumed in the form of fatty fish such as cod liver oil, swordfish, salmon, and sardines. Because of the history of risk related to vitamin D deficiency, it is fortified in common breakfast foods such as milk, orange juice, cereal, and yogurt. The body produces 7-dehydrocholesterol that is activated by ultraviolet B photons to go into skin cells and form pre-vitamin D and later cholecalciferol, or D2. The current vitamin D supplementation contains between 400 to 2,000 IU. Vitamin D deficiency in humans is indicated by a frequency of illness, fatigue, bone and back pain, depression, impaired wound healing, bone loss, hair loss, and muscle pain. Vitamin D plays an important role in the health and development of teeth and skeletal system and muscle function by maintaining the mineral balance in the body. It is essential for calcium utilization and is also considered an important component in the production and regulation of insulin secretions in cases where there is increased demand, such as with obesity. Vitamin D counteracts the harmful effects of advanced glycation products used in the increased development of insulin resistance and therefore type 2 diabetes. When it is obtained through the diet, vitamin D is absorbed by the micelles in intestinal cells within the duodenum and proximal jejunum with the help of bile and transported by chylomicrons to non-hepatic tissues throughout the body. Vitamin D produced by the body diffuses out of the skin and is transported to the blood by vitamin D binding protein. This form of vitamin D is then converted into calcitriol or 1,125-OH-D2 in the kidneys. Any excess vitamin D is stored in the liver and adipose tissue. If needed, vitamin D in the liver is converted to 25-OHD through hydroxylation by cytochrome P45 hydroxylases. Is then secreted and then transported to the blood, with the excess being stored in the muscles and adipose tissue. Vitamin D stored in the adipose tissue is not as bioavailable and takes longer than vitamin D stored in the muscle. This information is important considering the fact that in people that are overweight or obese, vitamin D is more likely to be stored in the adipose tissue, which means it has less bioavailability. The decreased bioavailability leads to vitamin D deficiencies in people with obesity. Based on consequences of the advanced glycation process noted above, people that are obese are at increased risk of development of type 2 diabetes. The PICO statement for this systematic review raises the question: in non-diabetic adults ages 19 years of age with overweight or obesity with a BMI over 26, what effect does vitamin D have on insulin sensitivity, insulin resistance, and therefore the risk related to developing type 2 diabetes compared to a placebo? The methodology used to research these articles includes specific eligibility criteria, sources, search terms, study selection, data collection processes, and data items. The eligibility criteria, as stated before, were no older than 10 years old, and everything was required to be in English language. My information sources included Scopus, ProQuest, Wiley Online Library, Gale, PubMed, and Academic OneFile. The search criteria was one statement, which was vitamin D supplementation and insulin sensitivity in obese non-diabetic adults. The inclusion for the study selection was anything that focused on information from these four parameters: insulin sensitivity, insulin resistance, non-diabetic adults, obesity and insulin sensitivity, vitamin D deficiency and obesity, and vitamin D deficiency and insulin sensitivity. The exclusions were studies on subjects with diabetes, adolescents, children, and other vitamin or mineral interventions. The data collection process involved keeping the objective clear and concise with a set of specific search terms, population criteria, and specified outcomes. The data items were developed from the collection process with outcome measured through OGIS, or oral glucose insulin sensitivity, ISI, insulin sensitivity index, and oral glucose tolerance test, OGTT, with OGIS testing being consistent among every study. The number of original hits from my search was 1,225. For the study selection, 16 studies were screened and assessed for eligibility, credibility, and relation to the subject at hand. Only 3 studies were included in the review. Certain studies were excluded because they focused on adolescent or children, diabetes, or other populations with underlying conditions such as cardiovascular disease or kidney disease. Others were excluded because they failed to meet the main outcome of any effect on insulin sensitivity or insulin resistance from vitamin D supplementation. The interventions criteria for the study was open to any form of vitamin D supplementation. This includes oral intake through food or vitamin supplements. The study, conducted under Jagnik Paul, was performed using 71 subjects. The PICO was to determine the short-term effect of vitamin D3 supplementation on insulin sensitivity in apparently healthy middle-aged men that were centrally obese. The follow-up period was 6 weeks, and the researchers stated that they had nothing to declare on conflict or bias. The study conducted under S.S. Harris was performed using 89 subjects. The PICO was to determine whether vitamin D supplementation improves insulin secretions, insulin sensitivity, and glycemia in African Americans in prediabetes or early diabetes. The follow-up period was 12 weeks, and the authors also declared that they had nothing to declare on conflict of interest. The study conducted under Mirjam Osterhoff was performed using 130 subjects. The PICO was to examine the effect of vitamin D supplementation on insulin sensitivity and beta cell function in overweight, vitamin D deficient non-Western immigrants at high risk of diabetes. The follow-up period was 16 weeks. The intervention for the study conducted under Janet Paul produced results showing the intervention group that started with a baseline mean of 35 of active vitamin D and had gone up to 36.5 of active vitamin D. The placebo group that started at 36 of active vitamin D had gone down to 30 active vitamin D. The results of the OGIS, or oral glucose insulin sensitivity test, showed that the insulin sensitivity of the intervention group that had decreased to 412 and the control placebo group had increased to 434. The intervention for the study conducted under S.S. Harris produced results showing the intervention group with vitamin D levels at 81.1 and the placebo group with vitamin D levels at 37.4. The results of the MISI, or risk related to morbidity based on insulin sensitivity, decreased by 4% in the intervention group, but it increased by 12% in the placebo group. The intervention for the study conducted by Mirjam Osterhoff produced results showing the intervention group with vitamin D concentrations that increased from 25 to 58, and the placebo group with vitamin D concentrations that stayed between 22 to 24. The results of the insulin sensitivity test showed that there was no effect of vitamin D supplementation on insulin sensitivity. Each article selected provided information on the connection between vitamin D, insulin resistance, and sensitivity, and obesity in adults. For the study conducted under J. Nekpal, in 2008, a neutral quality, double-blind, randomized placebo-controlled trial was conducted in order to assess the effect of a single dose of 3 doses combined of 240,000 IU vitamin D3 supplementation versus the placebo on insulin sensitivity in 71 healthy and centrally obese adult men with a mean age of 35 years old during a 6-week trial period. The results indicated that there was an increase in oral glucose insulin sensitivity with vitamin D supplementation by per protocol analysis with a p-value of 0.038 and an intention to treat analysis with a p-value of 0.055. This was relevant to the review because the researchers concluded that vitamin D3 supplementation improved postprandial insulin sensitivity in healthy men with insulin resistance and central obesity. For the study conducted under S.S. Harris in 2012, a positive quality randomized placebo-controlled trial assessed the effect of 4,000 IU per day vitamin D3 supplementation versus placebo on insulin secretion and insulin sensitivity in 89 obese or overweight adult African Americans with a mean age of 56 years old during a 12-week trial period. The results showed that in intervention group, insulin sensitivity decreased by 4% and insulin secretions increased by 12%. In the placebo group, insulin sensitivity increased by 12% and insulin secretions increased by 2%. This was relevant to this review because the researchers concluded that supplementation of 4,000 IU per day of vitamin D3 had divergent effects on insulin secretions and sensitivity. For the study conducted under Osterhoff in 2014, a negative quality randomized placebo-controlled trial assessed the effect of 1,200 IU daily vitamin D3 supplementation versus placebo on decreasing insulin resistance on 130 overweight non-Western immigrants at high risk for diabetes and at a mean age of 42 years of age. Based on the results obtained, there was no effect on insulin sensitivity. This study was relevant to the review because it showed that 1,200 IU per day of vitamin D was not sufficient at affecting insulin sensitivity in obese adults. The implications of this study stem from inconclusive evidence reviewed from each article. These studies show that vitamin D could possibly be used as a possible intervention and treatment method for individuals with overweight or obesity in the prevention of type 2 diabetes. Healthcare professionals may need to be aware of the importance of detecting insulin resistance in vitamin D deficient individuals. It should be noted that vitamin D deficiencies in obese adults could be a precursor to type 2 diabetes. This also pertains to obese adults living in cold weather climates. Based on the results of the review, the preferred supplementation for obese adults at risk for type 2 diabetes could be 4,000 IU per day of vitamin D. Vitamin D supplementation of 4,000 IUD for 6 weeks in patients with overweight or obesity may improve insulin sensitivity and reduce insulin resistance. The conclusion from the study and overall research examination states that vitamin D supplementation of 4,000 IU or greater per day was sufficient in increasing insulin sensitivity and decreasing insulin resistance in individuals that are obese and at risk for type 2 diabetes. Funding was provided by authors associated with the Clinical Research Grant of American Diabetes Association and John Mayer from U.S. Department of Agriculture and Human Nutrition Research Center in Aging at Tufts University. The Osterhoff study got their funding from Merck & Co. for the analysis of serum 25 OHD concentrations in the longitudinal aging study in Amsterdam. The strength of the study under J. Paul was that it was a double-blind randomized controlled trial conducted in a country with high prevalence of diabetes and hypovitaminosis, D using an accepted surrogate index of insulin sensitivity selected in the basis of a pilot trial. The limitations were a high drop rate of 26%, a small sample size, short duration of follow-up, restriction of the study population to men, and that most of the subjects were severely vitamin D deficient at the start, and most of the S group did not reach normal levels. The strength of the study under S.S. Harris was that it was a randomized, placebo-controlled design, its 2-hour oral glucose tolerance testing, and its use of high enough vitamin D dose 4,000 IU per day for most subjects to achieve a 25 OHD level over the 50 that was recently recommended by the Institute of Medicine. The limitations were the small sample size and the short duration of the study. The strength of the study under Osterwald was the severe vitamin D deficiency of our population with gross overweight and high diabetic risk. The limitations of the study was that the treatment group appeared slightly healthier at baseline despite a well-performed randomized procedure. Potential future research questions may include what are the effects of 125 dihydroxyvitamin D and PTH on calcium economy in blacks versus white. It is also recommended that all studies be no less than 6 months in length. Thank you, and I hope you enjoyed this presentation.